Hi, this is Elliot Fishman. Welcome to part 2 on Chromophobe renal cell carcinoma. We went through a lot of very important points, and I just want to highlight a few of them from our article about the calcification rate in chromophobes. But again, this is something I don't see as often as we reported even here. Some articles 1/3. We reported 14%. And in most of the cases when there were calcifications, they were small. Again, the solid nature of the tumor is very, very important. Well-defined, sharply marginated, rarely cystic, though occasionally they had a central scar, which was better seen with contrast than in the non-contrast CT. But again, it doesn't have a very aggressive look to it. I mentioned before about the enhancement, that it never reaches 90 Hounsfield units. Again, clear cell is much higher by about 50 at least, but even papillary typically goes above 90. Remember, normally when we separate clear cell from papillary, we say that it should be at about 100 Hounsfield units would be the separation, and then you'd be 99% accurate. But these chromophobes are even less dense, less bright, less enhancing than the papillary renal cell carcinomas. And again, presentation, most are going to be incidental, but think of large tumors, well-defined. Think about that possibility when you're thinking about the differential diagnosis. And again, most importantly, of all the subtypes of renal cell, it has the best prognosis with 5-year survival over 90%. So, a very important diagnosis, and surgery is typically the way we manage these patients. Again, the variability will vary a little bit based on the protocols. I mentioned in this article here about partial nephrectomy, which can be done and typically is done in these patients. Again, if the tumor is exophytic, especially aggressive management with partial nephrectomy is important. Remember, these days, you have to explain why you're doing a nephrectomy and not a partial nephrectomy, whether you're dealing with clear cell, papillary, or chromophobe, because the results from partial nephrectomies, as long as the patient is eligible, is nearly equal to that of a classic nephrectomy. Examples: solid mass, well-defined right kidney, non-contrast, 39. Okay, this could really be anything, but when I give contrast, look how little it enhances. Okay, it reaches at best 75. It's well defined. I don't see a central scar. I do not see any calcifications. Here it is again on the coronal view, nicely defined, pushing on the renal artery. These tumors rarely involve the renal vein. Here's the excretory phase where it reaches 93. You can see some areas of necrosis. Yes, could you consider a papillary? You could. Papillaries usually aren't as large, but you still can consider a papillary. I would not be considering a clear cell because it's not vascular enough. And here's the tumor with a little bit of imagination. Its sharp margins are easy to see. Maybe there's a central scar in the patient's tumor. Another example, a mass that's literally the same density as the cortex is in the posterior aspect of the mid portion of the right kidney. You can see the attenuation is about 28 Hounsfield units, which is the same as cortex. And then when you give IV contrast, the normal kidney enhances to 116, and this only enhances to 72. Remember, we said that chromophobes do not enhance as much as the cortex. A really nice example as it goes from 26 to 72 Hounsfield units. And here it is again, well-defined, sharply marginated. I don't see any calcification. Here it is as we go from venous to excretory phase. The kidneys excrete contrast normally, and the mass was well-defined. Now, I mentioned calcification. Here's a non-contrast scan with mass in the right kidney. This has really what I would call dystrophic calcification. There are multiple foci of calcification, and I have to admit from this alone I could consider a clear cell. When you give the contrast, you can see on the image on your right, the lesion does not enhance to any great degree. It's really minimally enhancing. You can see it's a good-sized tumor centrally located, which will mean this cannot be a partial nephrectomy because it's too close to the central vessels. But it's solid, but again, not as bright as the cortex. Again, the borders are irregular. It does have calcification. When you think papillary versus chromophobe, papillary rarely has calcification. We said chromophobe reporting up to 1/3 with calcification. Our experience is probably half that, but this was a chromophobe renal cell carcinoma. Now, I mentioned they can be multiple. You look at non-contrast, there's something in the upper pole of the right kidney, and there's a mass in the lower pole of the left kidney laterally, but they're the same density as the cortex. When you give the patient contrast, look at the mass in the left kidney. That's the first thing to see. You also can see the mass in the upper pole of the right kidney. You can see a mass within the kidney itself. Actually, maybe here as well, but this is definitely a mass. So you're talking about at least 3 lesions. Here you can see there is actually 4 lesions centrally in the kidney, and you can see it very nicely in the lower pole, the 2 lesions in the mid pole of the kidney, as well as the lesion in the contralateral left kidney. Here it is again with the central scarring, particularly in the upper pole lesion on the right side. Again, could this be papillary? Yes, but papillary usually is not multiple. Chromophobe can be multiple. Could this be clear cell? Well, clear cell also unusual to be multiple, but it can be, but it's usually much more vascular. So these lesions are somewhat vascular, but they're multiple. A really nice example of multiple chromophobe renal cell carcinomas. So just a really nice example, and you can see there were areas of scarring in the kidney also noted. But here it is, you can see nicely from the early phase imaging that the lesions do not enhance nearly as well as the cortex of the patient's kidney. Again, one of the key features in looking at chromophobe renal cell carcinoma. And here it is on the excretory phase imaging. The lesions are low density. It almost, when you look quickly, say, could this be a high density renal cyst? Obviously, we look across phases, but if you only had excretory phase, you could see why that might be a challenge to you. So again, we never only look at one phase, particularly if a lesion measures an attenuation above 10 Hounsfield units. So again, just a really, really nice example. And here's that same patient with cinematic rendering. You can see nicely the lesion in the upper pole, right kidney, the lesion lateral lower third of left kidney. You can see the lesion now in the lower pole of the right kidney, the textural changes compared to the normal cortex. And again, cinematic rendering is very good for preoperative planning. This patient did undergo surgery with multiple partial nephrectomies. Okay, complicated for the surgeon, but a good surgeon can surely do this, and they did. And here's just a few more images. Remember, cinematic rendering is commonly used for looking and staging tumors, but also for preoperative planning. Another example, large mass left kidney. Could be any tumor of the kidney, but it's large, but does not enhance a whole lot when you give IV contrast in arterial phase. There's a few small nodes present. You can see it compressing around the renal vein. This case does have some vascularity, but it's not very vascular in general for the whole tumor. Here it is well defined and infiltrating on the coronal views in the upper half of the left kidney. Here it is again with some coronal and 3D rendering, very nicely showing you the mass. Again, a large tumor. Looking at its extent, particularly on the image on the left, this would not be a case for a partial nephrectomy, but a total nephrectomy will cure this patient. And again, you could see some vascularity in the lesion. It's a little bit more vascular than some of the cases I showed you. And again, we did make the point that there can be some vascularity when you look at these tumors. And here on the MIP imaging, it almost does look like a little bit of neovascularity on these images right here. So it can be a bit tricky. This would be a harder one to feel comfortable correlating a chromophobe renal cell carcinoma. But here it is, and those small vessels do wash out. But again, when I see neovascularity, sometimes clear cells are not very vascular, so I need to at least think about that possibility. And again, a few more images showing you the lesion. And again, 3D imaging, very helpful in the extent of lesion, very helpful looking at the vasculature, and also looking for central scar or neovascularity. And here's the lesion on the excretory phase. You can see its low density compared to the cortex of the patient's kidneys. There does appear to be some distortion of the calyces to the upper pole of the kidney. Here's that same patient again. We're giving you all of the views, showing you nicely the mass pushing on the left renal vein, but the renal vein was not invaded. This is with cinematic rendering. You could see some of the vascularity and what looks almost like septations within the lesion, which would be unusual for a chromophobe renal cell carcinoma. Again, very nicely shown here and here on these additional images. So again, a very variable tumor. It's always interesting to me that we have very specific signs of tumor. Never enhances above 90, well-defined, usually larger, usually no adenopathy. But not every case follows every one of the rules, which is why it's kind of a challenge. It'll be interesting looking forward when you look at lab values as well as the CT appearance, if AI can help us be more accurate. And I think the answer will indeed be yes. And here you can see some distortion of the upper pole calyces, which often is not due to tumor invasion, but just simply to the large bulky tumor and mass effect. But again, can be somewhat challenging. Another patient, bilobed mass in the left kidney. It looks like almost is pushing on the kidney in a way that I might even consider lymphoma. There's a cystic component. It looks like there's renal vein involvement, at least on these images. But this was a chromophobe with negative nodes and negative margins. Look how large the tumor is. Look how it pushes by the aorta, by the renal vein, by the left psoas muscle. And we were worried, but at surgery, the surgeon was able to remove it, and there was no spread of disease. So I think one of the challenges is when you have very large tumors, particularly large renal masses, even if they're not very aggressive, the fact that they involve multiple planes and push things makes it difficult for us to be comfortable and say there's no tumor spread. So here very nicely on the arterial map. But again, you see this tumor is not very vascular. And again, it's large. Too large to me for a papillary. Could be a clear cell, but again, needs to be more vascular. So think about that 5% of chromophobe renal cell carcinomas. And again, as we get toward the delayed phase imaging, the lesion has some areas of cystic change. It's generally low attenuation. Here it is very nicely on the patient's cinematic rendering. Just a really nice example, and you can see how the cinematic rendering shows the tumor adjacent to vascular structures, but does not show any invasion of those same vascular structures. Just a really nice set of images. Now, what about this case? Hematuria. I'm looking, and look at that small lesion in the right kidney. Now, could this be a small renal cell carcinoma the lesion's enhancing? And the answer is it's not a simple cyst, and it's not a high-density cyst. It's a renal mass, and with the increased vascularity, I would have guessed we're talking about an incidental renal cell carcinoma. The patient already had had a left nephrectomy. This was biopsied. You can see it's interesting. It enhances over 100 Hounsfield units. This was resected. and this ended up being a 1 centimeter chromophobe renal cell carcinoma. A very unusual appearance. It's a small lesion and it's vascular. I would have surely said a clear cell renal cell carcinoma. Now, what about this case? Same. Look at that lower pole of the right kidney. Look at that mass. Just a really nice case. And again, a very, very important diagnosis. Again, it does wash out, but based on its original enhancement, I would have pushed for a clear cell rather than for chromophobe renal cell carcinoma. So again, something to think about. It also makes the point about small renal lesions. You have a 1 centimeter lesion, but it's enhancing. Now, if patients are older, the patient may be followed. We commonly will follow patients who have comorbidities or don't want surgery with small renal tumors because the majority of small tumors under 2 centimeters may not grow or grow very slowly, and you could monitor the patient. And this might have been a case of monitoring, except this patient was 47 years of age. So let's do this. Let's stop there and let's come back and look at some more cases, including this case that has calcification, and let's finish up our talk on chromophobe renal cell carcinoma. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.